We are at the hour, so welcome everyone to the third and final webinar in our series, Building Resilient Systems Towards Cervical Cancer Elimination. I'm Julie Tarode, one of the directors of the Institute of Cancer Policy at King's College London and the IGCS Access Initiative facilitator. The key message from webinar 2 on HPV screening and treatment of cervical cancer was that the solutions are in the community, working with community leaders, partnerships with community groups, and engagement at grassroots level to build knowledge, acceptance, and uptake of life-saving screening tests and follow-up treatment when needed. I'm sure we'll hear similar examples as we shift our attention to pillar one. If you missed the first two webinars, you can catch up using this QR code. You'll be linked to the final recordings and the meeting summaries on the IGCS webinar. Today's webinar will focus on HPV vaccination as a foundational pillar of the WHO global strategy towards elimination of cervical cancer. This session will share progress towards achieving high vaccination coverage across the North American region and highlight strategies to ensure equitable access for all young people. We've selected exciting examples from programs in Canada and the United States to learn from, look at successful initiatives and identify opportunities to accelerate uptake and explore innovative delivery models that extend beyond the traditional school-based programs. So let me provide maximum time to our expert speakers. I'll hand over to our moderator today, Dr. Heather Brandt, who is Senior Director of the St. Jude HPV Cancer Prevention Programme. Over to you, Heather.
Thank you so much, Julie. It's really been a pleasure to work with you on this webinar series and the forthcoming workshop focused on elimination. So let's go to the next slide, please. I want to mention a few housekeeping items as we get started. We encourage you to submit questions using the Q&A feature on your Zoom control panel. We're going to do our best to address as many of those questions as possible. And a recording of this webinar will be available in the future on YouTube and through the Access webpage. We also encourage you to use the chat, introduce yourselves, and feel free to send helpful links and generate some collaboration. Next slide. I'm very excited to welcome our presenters and discussants today who are going to bring to us a wealth of expertise spanning HPV vaccination. We have Natalia Katz of PAHO, Teresa Norris with HPV Global Action, Gila Shapiro with the University of Toronto, Sandy Pingali of the CDC, and Noel Brewer with the University of North Carolina at Chapel Hill. And then Carla DeSisto of the CDC will serve as a discussant for the moderated panel session. So thank you all very much for joining us today. All right, without further ado, to kick off our presentations and set the scene for the current state of HPV vaccination as one of the three pillars in the WHO elimination strategy, it's my pleasure to welcome Natalia Katz. Go ahead, Dr. Katz, share your screen and get started.
Hello, thank you. Thank you. I'm sharing. Yeah. Minutes. No. No,
That's all right.
Yes. Okay.
It's not yet in slideshow mode.
Here.
Not quite yet.
Yes. Now.
Let's see. There you go. All right. Thank you, Dr. Katz.
Okay, thank you. I'm trying a new technology now. Thank you very much for the invitation. Good afternoon, everyone, and thank you My name is Natalia Katz. I'm an international consultant at the Comprehensive Immunization Special Program in the Pan American Health Organization. Today, I want to walk through where the region of the Americas stands on HPV vaccination and what it will take to reach cervical cancer elimination. I will cover three things in the next few minutes: why this matters, where we stand, including the gaps, and what a realistic path forward looks like. Let's start with why HPV vaccination matters. Let's ground this in numbers. In 2022, cervical cancer caused an estimate of 662,000 new cases and almost 350,000 deaths. Worldwide, more than 78,000 cases and roughly 40,000 deaths in our region alone. The burden isn't even, though incidence and mortality rates vary widely between countries, even within our region. That heterogeneity will be a theme throughout this talk. This is why WHO set the 90-70-90 targets for 2030. 90% of girls fully vaccinated by age 15, 70% of women screened with a high performance test by ages 35 and 45, and 90% of women with cervical cancer disease receiving treatment. The vision, a world free of cervical cancer. The objective, fewer than 4 cases per 100,000 women per year in every country. So how close are we to that 90% of target? Let's look at where the region actually stands. This slide is about policy heterogeneity because coverage gaps often start with differences in how programs are designed. On the left, globally, more than half of countries have already adopted a one-dose schedule. The Americas are even farther ahead at 61%. This matters because the one-dose schedule is easier to implement, it cuts costs, simplifies logistics, and reduces dropouts with evidence, showing it just as effective as multi-dose schedules. On the right, gender-neutral vaccination, globally just over half of countries vaccinate both girls and boys. In the Americas, that reaches 77%, reflecting the region's commitment to broader HPV disease prevention. However, adopting evidence-based policies is only one part. The real challenge is turning it into high equitable coverage. That's what I will show you next. Coverage has been recovering after COVID-19 setbacks. First dose coverage, I look for laser. First dose coverage among girls dropped to about 53% here in 2021 and recovered to roughly 70% by 2024. Coverage among 15-year-old girls is now approaching 76%. This is a solid progress, but still below the WHO target of 90%. We are doing considerably better than the global average, you can see here. Global first dose for girls was only 31% and 8% for boys in 2024. But the map on the right that we have here, the map shows real heterogeneity within our region too, with coverage varying substantially between countries. Our challenge now is turning these gains into high equitable coverage everywhere, down to the municipal level. The 2025 WENIC coverage estimates will be available today. So why the gap between policy and performance? Let's talk about the barriers. Across the region, we continue to face several common barriers that limit HPV vaccination coverage. First, School-based vaccination is the main delivery strategy in most countries, but implementation challenges and out-of-school adolescents mean many are still missing. Second, insufficient training of healthcare providers who often lack the confidence to consistently recommend the vaccine, even though provider recommendation is one of the strongest predictors of acceptance. Third, low awareness and knowledge in communities, limited understanding of HPV, how it is transmitted, and its link to cervical cancer contributes to vaccine hesitancy and low demand. And four, inequitable access, geographic and social gaps limit access, and isn't only in a rural problem. Large cities struggle too. And finally, gaps in information systems, incomplete or fragmented data, mass coverage gaps at the subnational level. These barriers compound each other, which is why no single intervention will be enough. Given that, we need a coordinated, comprehensive response. Improving HPV coverage in the Americas doesn't depend on one intervention. It requires a coordinated approach across different areas. First, strengthen a school-based strategy to reach more adolescents. Second, well-trained healthcare providers who recommend and prescribe the vaccine with confidence. Third, community engagement and clear communication to build trust and demand. Fourth, strong immunization information systems to monitor coverage and target action. Fifth, regional technical cooperation, PAHO, Pan American Organization, works in sharing best practices across countries. And sixth, strategic alliances with professional societies to amplify advocacy and impact. The message is sustainable, multi-sectoral, equity-focused action across the health sector, education, communities, and partners to reach everyone, everywhere. Let me close with the message I most want to leave with. Reaching 90% of HPV vaccination coverage is not only an immunization goal, it is an essential milestone toward eliminating cervical cancer as a public health problem in our region. And achieving it requires strong immunization programs, trusted partnerships, and community engagement, working together in isolation. We have the tools and a regional policy environment ahead of the global outreach. What we need now is sustained political commitment, close the gap between the policy we've adopted and the coverage our adolescents need. So thank you very much for your attention. I'm happy to take any questions and my contact information on the screen.
Thank you so much, Dr. Katz. And Julie captured a quote that you said during your presentation. I think that really is important for us to think about that quote, coverage gaps often start with policy gaps and program design, and then how those unfold in practice. So thank you for setting the scene on HPV vaccination. Let's now transition to Dr. Gila Shapiro, who will be presenting from the Canadian perspective. So Gila, if you would go ahead and share your slides and get started.
Thanks very much. Can you see my slides okay? Can you hear me okay?
Yes, you're all set.
Thank you, Heather. Well, thanks everyone. I'm very pleased to be here to present today on the Canadian context. I'm going to be presenting a little bit of an overview, and then my colleague, Teresa Norris, will present a more in-depth scenario about what's happening in Canada, and that way we hope our slides will complement each other. So to begin with, Canada has committed to WHO's cervical cancer elimination goals that you just heard a little bit about. HPV vaccination being the first pillar of elimination. However, in Canada, cervical cancer rates have been stable or have increased. An article published recently in our National Medical Journal in April reported that after decades of meaningful declines, incidence rates of cervical cancer have plateaued well above the WHO elimination targets and have even increased among younger age groups. So, as you are likely aware, Canada has, like other countries, have publicly funded HPV vaccination programs across all our provinces and territories. And we've also have integrated HPV vaccination into broader cervical cancer elimination efforts. So the issue for Canada is not only does HPV vaccination work or whether it can be introduced, but it's really how to ensure everyone benefits from it. Here you can see a partial view of HPV vaccination in Canada. As you can see, there is substantial variation across the different jurisdictions. Variation by school grade, number of doses, and also uptake rates. Our team recently reported using national data, CNIX data, that in 2021, 84% of children received at least one dose of HPV vaccination. However, there is substantial variation in uptake rates across regions and also amongst populations. But I think it's important to step back and say what is working well in Canada and what can be exported to other places and what is in common with other contexts as well. So in Canada, across our jurisdictions, we have publicly funded school-based programs, as I mentioned, and gender-neutral vaccination programs that were introduced from 2013 to 2017. We also have strong national recommendation from federal agencies, as well as support from medical and scientific societies. And we do have increasing alignment with WHO one-dose strategy, and that's the case in 5 of our jurisdictions at the moment. Here you can see some evidence about our publicly funded school-based HPV vaccination that we gathered a number of years ago. At that time, HPV vaccination was available only in some regions for boys. And so our team conducted a natural experiment when looking at only vaccination for boys in some contexts compared to others. And what we found in this longitudinal sample of Canadian parents of children 9 to 16 years of age was that receipt of HPV vaccination in boys in publicly funded school-based programs was much more effective than not having a program available. And even more interestingly, in multivariable analyses that also included sociodemographic variables, vaccine knowledge and attitudes, and healthcare provider recommendation, we found that vaccination of boys had much higher odds in regions that did have publicly funded school-based programs. So the importance of these programs cannot be underestimated. The odds ratios were 10 to 11. But we do have our challenges. Canada, like I mentioned, is not monolithic, and we do have decentralized health system that does, and there is substantial variation. So we do have a number of differences in our uptake rates, as well as in our program schedules. For example, some provinces have adopted broader catch-up policies, including once eligible, always eligible approaches. And other provinces have included opt-out default consent policies, which means that individuals have to opt out of being vaccinated in the consent programs. So that is a difference across our provinces as well. However, there are a number of important opportunities for Canada, and some of these are similar to what my colleague Dr. Katz just reported. Very important for Canada is to strengthen our immunization registries so we better understand uptake rates that are being reported by different jurisdictions. We have better data integration and real-time monitoring. Also important to expand access through extending school-based vaccination and flexible catch-up pathways. And Teresa Norris will discuss this a little bit further, not only with age groups, but also location. Implementation of opt-out default consent models holds a lot of promise for Canadian regions. And implementing equity-focused approaches for underserved populations, including co-design and tailored strategies, alongside strengthening provider recommendations with focus on cancer prevention messaging. So with that, I look forward to the discussion and thank you for including me in the panel today. Thank you.
Thank you so much, Gilla. And I put a few of the links to some of those resources that she shared during her presentation in the chat. So now we're going to transition to our next presenter from Canada, Teresa Norris. So Teresa, take it away.
Great. Can everyone hear me and see my slides okay?
Yes,
Good.
you're all set.
All right, I'll start back at the beginning here. So thanks for having me. Again, I'm another voice from Canada talking about how in our context, we've really moved past using just school-based vaccination programs to really look at how we can optimize the rollout for vaccination through our community pharmacies. So we know, especially in Canada, that school-based vaccination programs are really the cornerstone of how we're having so much success with our younger populations. Unfortunately, we are missing people. And so we have to figure out what are we going to do to have that bigger access to reach all of the country. So we're missing adults and adolescents that either didn't sign the consent form at school or missed that window of the girls or boys vaccination programs. And then we also have additional delivery models that are needed to improve that access to our patients, our oncology units, and to the older populations across Canada. So community pharmacies represented a really important opportunity in Canada. And I'm going to discuss a little bit more about our experience in Quebec. But first, taking a quicker and more in-depth look at that, we have our 18 to 26-year-olds that were out of that risk group. Then we have all those adults that are in new relationships or even in long-term relationships, or our males that are having sex with males populations that are all having access to our free vaccination programs that we're offering across Canada that are missing it. We have our new immigrants. We have a lot of people across Canada that don't have a family doctor or a family physician or any type of healthcare. So we're missing all of those people. And then we are also, the group that we're missing sometimes that we don't talk a lot about is when we're already in an appointment with a medical professional and then that medical professional isn't taking that opportunity to be discussing the opportunity to vaccinate. And again, these are all the reasons why the pharmacy portal is a really interesting one. So taking a look at the case of Quebec, we have almost 2,000 community pharmacies that are across the province of Quebec. And we have a little over 10,000 pharmacists. So we have quite a few pharmacists that are across the province. Now, we have pharmacies across the world and we have pharmacies across all kinds of contexts. So one of the things that we have in common is that pharmacists are highly accessible because they are a healthcare professional. A lot of people live close to a pharmacy. I know in the area I live in alone, I think I counted last week, there was 7 pharmacies within a 20-kilometer radius. And in Quebec, specifically, pharmacists are authorized to administer vaccines, which is not the case across all of Canada. But these end up being bureaucratic and governmental decisions that could be tweaked and adapted so that pharmacists could have the authority to prescribe and vaccinate, not just in Quebec, but in other parts of the country. And pharmacies are already in Quebec providing a multitude of other vaccines. We drove a lot of our COVID-19 vaccines through the pharmacy's shingles as well. These are offering important opportunities and portals for our older populations that much prefer to go to their local pharmacy. And pharmacists in Quebec have established relationships with patients and clients and families. And I don't think that's exclusive to Quebec. I think a lot of people end up having very close relationships with their pharmacists over time. And then, of course, in pharmacies, luckily, they have vast hours of opening. They're typically open 7 days a week, and they're usually open from early in the morning until later into the evening. So this offers a really great opportunity for that access as well. So when we have our visit, I think the biggest thing that we have to be focusing on is pharmacists have to have a clear, brief discussion about that vaccination opportunity. I'm going to skip to the next one because I think this is the more important thing to be covering, that access alone is really not going to be the only thing that we have to be considering. We have to be considering the cold chain supply, where the warehouse is the pharmacy keeping doses on hand? Do we have staff that's available to do the vaccinating? Have we integrated that into our workflow? Are we using our opportunities with the clients and people that are coming through the pharmacy to have that discussion and have a little private section of the pharmacy to have an important discussion. And are we using that opportunity when they show up at the counter with their deodorant or their tampons or the condoms or whatever their question is, to take that good moment to have that discussion about offering that opportunity to vaccinate, because we really do need to start looking for those opportunities as a pharmacist in those pharmacy settings. And then from a systems perspective, to make sure that those funding models are in place for the public, the private or out-of-pocket client that's showing up at the counter, making sure that this is linked to the registries. We know that there's issues with the registries being connected across the country, but making sure that we're making that clear, and that the referral pathways are in line, and that the public health partnerships exist so that non-for-profits are also driving the public to be using that access. So just to look over what I'm discussing here, we really do need to be expanding the access to pharmacies, not just in North America, but in other places, so that we reach people where they live and where they work and where there are trusted professionals. We need to start having that conversation about HPV vaccination, because it's an opportunity to be preventing cancers. And pharmacists are trained and capable and ready to make a difference, not just in Quebec, but in many parts of North America. And this can drive the impact for more vaccinations today, which means fewer cancers tomorrow. So thank you all for your time and for listening. And this is the best way to reach me, by my email address here. Thank you.
Thank you so much, Teresa, for sharing this. I think in addition to the school-based approach, which has had great success, that there are people who are missed. And so thinking about other strategies, and pharmacy certainly offers that structure and that potential pathway. Thank you for sharing that. So there are some questions for Gilla and Teresa in the Q&A and the chat. If you guys wouldn't mind taking a look at those as you can, and we could come back to some of them during our moderated discussion. We now are going to transition to hearing some more about the U.S. perspective. We're first going to hear from Sandy Pengali of the CDC, and I can see that Sandy is sharing her slides here. So we'll turn things over to Sandy in just a moment. Hi, Sandy. Do you want
Hi,
to?
can you hear me okay?
We can hear and see you. You have it in notes view, so you might want to switch the display setting.
Okay, hold on.
Yeah.
Did that do it or no?
It did not.
Let me stop sharing and try again.
Okay.
How about now?
It must still be loading.
Would you like to share it?
Sure, we'll go ahead and share. If the team could go ahead and share those. Thank you.
Just give me 1 second while I'm pulling them up. Apologies for the delay.
Thank you. Sorry about that. Not sure why it wasn't showing the right view.
I apologize,
So-
everyone. They are not.
Okay, I'll just go ahead and share then. I have them called up. So let me just go ahead and do that. So in the interest of time, we can keep moving. All right, hopefully you guys can see. All right, go ahead, Sandy.
Thank you. So hi, everyone. My name is Sandy Pengali, and I'm an epidemiologist in the Immunization Service Division at CDC, and I'm the SME for the National Immunization Survey team. And today we will review the key points of the 2024 NIS team data with a focus on the HPV vaccination results. And analyses of the 2025 NIS team data are currently underway and will be published in MMWR in early fall. So next slide, please. So, vaccination coverage among adolescents in the United States is monitored through the National Immunization Survey team. And in this slide, I'll just very briefly describe the methods of NIS teen. So, the NIS teen survey consists of two phases. The first phase is a random digit dialed cell phone survey of households with teens aged 13 to 17 years. And then the second phase is a mailed survey of vaccination providers. So the household survey collects sociodemographic information and requests permission from the parent to contact the teen's vaccination provider. And then if permission is granted, a mailed survey is then sent to all vaccination providers identified by the parent. And vaccination coverage estimates reported by NIS Teen are based on the provider reported data, and teens are classified as being up to date based on the CDC recommended number of doses for each vaccine. Next slide, please. So NIS Teen has been monitoring adolescent vaccination coverage since 2006, and this line graph shows the trend in coverage with vaccines recommended for adolescents from 2006 to 2024. So one or more doses of Tdap is the red line, and one or more doses of MenACWY is the dark blue line at the top of the graph there. And coverage with these vaccines has been high and stable from about 2018 to 2023, with small increases in coverage in 2024. And then HPV initiation is the orange line, and HPV up to date is the green line. And coverage for HPV initiation and HPV up to date plateaued in 2022, and it is still lower than the other routine vaccines with the exception of the MenACWY booster dose, which is noted in purple there on the graph. Next slide, please. So as this is a very brief look at HPV vaccination coverage in the United States, I've highlighted several key results from the 2024 data in the next slides. So next, we're going to look at coverage stratified by metropolitan statistical area. Next slide, please. So this figure compares routine vaccination coverage by MSA status, and vaccination coverage in urban areas is shown in the dark blue bars. The light blue bars are for suburban areas, and then the purple bars are for rural areas. And then mostly urban areas were the reference group for comparisons here. So Tdap coverage did not differ by MSA status. Coverage with one or more doses of MenACWY was lower among adolescents living in mostly rural areas compared to mostly urban areas. And then coverage with one or more doses of HPV vaccine and the percent of adolescents HPV up to date was lower in mostly suburban and mostly rural areas compared with mostly urban areas. Next slide, please. So HPV vaccination coverage has been consistently lower among adolescents living in mostly rural areas than among those living in mostly urban areas from 2016 to 2024. So in this line graph here, urban areas are shown in blue, and then the rural areas are shown in purple. And the solid lines are for coverage with one or more doses of HPV vaccine, and then the dashed lines are for HPV up to date. So you can see over the past 9 years, from 2016 to 2024, there's been little progress in narrowing the urban-rural coverage gap. And in 2024, coverage with one or more doses of HPV vaccine and the percentage of adolescents HPV up to date was about 11 percentage points lower among adolescents living in mostly rural areas compared to mostly urban areas. Next slide, please. So now we'll transition into looking at HPV vaccination coverage by state. Next slide, please. So this map is showing coverage with one or more doses of HPV vaccine split into quartiles here. Overall U.S. coverage with one or more doses of HPV vaccine was 78% in 2024, and coverage varied across jurisdictions, ranging from a low of 59% in Mississippi to a high of 91% in Rhode Island. And we typically see that the New England states and some of the states in the Mid-Atlantic region and the Dakotas have achieved high HPV vaccination coverage, while the Southeast tends to have some of the lowest coverage in the U.S. Next slide, please. And then this map shows the percent of adolescents HPV up to date among adolescents aged 13 to 17 years, again split into quartiles. And nationally, 63% of adolescents aged 13 to 17 years were up to date with the HPV vaccination series in 2024. And here, coverage varied substantially across jurisdictions, ranging from a low of 39% in Mississippi to a high of 80% in Massachusetts. Next slide, please. So now I'll just quickly summarize the key points from the 2024 data. Next slide, please. So in summary, in the United States, HPV vaccination coverage has not increased for the third consecutive year in 2024. HPV vaccination coverage does continue to be lower among adolescents living in mostly rural areas compared to mostly urban areas, and we've seen little improvement in the difference in coverage over the last 9 years. And then HPV vaccination coverage continues to vary widely by state, with the largest differences in coverage seen for the percent of adolescents HPV up to date. Next slide, please. So thank you, and I'd be happy to answer any questions.
Thank you so much, Sandy, for providing that data overview. And as I was listening to you talk and thinking back to Gilla and also Teresa's talk, thinking about some of the similarities, and Natalia as well, some of the similarities that serve as a common thread about many people who are missing out on HPV vaccination coverage for a wide range of potential reasons, driven by system level differences, implementation differences, hesitancy, myths and misconception, all of that factoring in here. So now we're going to turn to Dr. Noel Brewer from the University of North Carolina at Chapel Hill, who's coming on to share his slides to talk a little bit more about potential strategies that we've already heard referenced in today's webinar. Noel, take it away.
Thank you so much. I'll be talking about ways to improve HPV vaccine uptake, and most of these insights also apply to other vaccines. I'll start with a few disclosures about some different roles that I have, as well as past funding. So provider recommendation has the single largest impact on HPV vaccine uptake. There is nothing else that compares to it. A provider recommendation raises HPV vaccine uptake from 24% up to 60% in a meta-analysis across 60 studies of 265,000 individuals. In trying to understand why it is that provider recommendations are so effective, we developed what we call the increasing vaccination model, which has been used globally for the last several years, including by the World Health Organization and the CDC. There are 3 predictors or causes in the model, and that leads to vaccination. And I should mention also that vaccination is a complex behavior that can involve scheduling an appointment, consenting, sometimes delaying, or even refusing. On the left-hand side is the first box, or cause of vaccination, which is people's risk beliefs, confidence, their motivation, their hesitancy. Then there are the social processes, the social world that they exist in, the norms that are around them that spread from others to them, and that they also propagate to other people. And then, of course, things like altruism and free riding. And then finally, there's direct behavior change. And I'm going to give you examples of each of these things in a minute, which is to build, and the idea is to build on existing motivation with nudges or reminders, or to shape behavior with more forceful means such as incentives or requirements. So I'd like to give you a quick summary of the evidence across randomized clinical trials for each of these. What people think in field box doesn't do that well. Messages that increase disease risk appraisal are not reliably effective, in part because they generally don't change risk appraisals. If you look at just a small subset of studies where risk appraisals have changed, then they do work. But it's hard for us to say ahead of time, this message is going to work and this message won't. So mass communication campaigns don't change behavior per se. However, they're very likely to change the policy context. They'll change the belief of policymakers and the general public's openness to various interventions that will be effective, that will show up in the blue box toward the end of my talk. So education campaigns that increase vaccine confidence are not shown to be reliably effective in any large way, nor decision aids, nor motivational interviewing. Although motivational interviewing clearly has some impact, it just doesn't have a large impact. Social processes, for example, descriptive norm messages are promising. There's not a lot of evidence, strong evidence for them. And then social network interventions that build on communication contagion, the idea that rather than having one communicator with a large audience of many people, instead there's this idea of complex contagion where the message comes from lots of different places in your social network, and as it starts pinging, that causes people to be more likely to change their behavior. Very promising, and there are some studies on this, but not enough for us to say that it's substantially strong evidence. And then altruism messages or free riding don't seem to work as a strong intervention. What really works are these direct behavior change or nudge interventions. So things like not only a healthcare provider recommendation, but a presumptive one. Reminders and recalls telling them to get back into the office. They're effective, but they're especially effective in certain circumstances. For example, when you mention the name of the clinic, this is in a clinic setting, not in a school setting per se. On-site vaccination like schools, we've heard about that. Default appointments, incentives, and vaccination requirements, all are reliably effective. Here's an example of one intervention that we developed. It's a 1-hour provider-led in-clinic training on doing presumptive recommendations. It increased HPV vaccination by 5 percentage points, which is quite a lot. And then it reduced the time to vaccinate by about 40%. There are updates on hpviq.org with the materials and also our latest version of the announced approach slides and script and so on. Default appointments are also effective. If you take a look on the left, people who opted in, meaning that they had to people had to opt out of an automatic appointment have the highest rate of vaccination at a flu clinic or at their doctor's office. People who had to opt in based on a letter that was sent to them had no different rate than people who had no letter at all. I'll close by mentioning that there is a lot of research on resilience to safety threats. So that a safety scare can be a big shock to a country. And there have been HPV vaccine safety scares in at least 7 countries. Looking across them, some of the commonalities are that the scare was the idea of the safety concern was imported from other countries. It gained momentum through traditional media coverage, and it was embedded through political leaders, delays by some vaccination programs in responding, and the absence of effective crisis communication plans. The good news is that all of the countries were able to increase HPV vaccine coverage or restart their introduction of the vaccine, and they did so by responding quickly, developing a broad coalition that involved providers, political actors, as well as community representatives. They shared credible messages that emphasize cancer prevention, not so much the transmission of the virus per se. And then they communicated across traditional and social media platforms. And with that, I'll pause. Thank you so much.
Thank you very much, Noel. And at this time, I want to invite all of our panelists to go ahead and join me on camera here. And as we get started with the moderated panel discussion, a reminder to our audience who's joining us live, we welcome your questions. We have some pre-developed questions that we'll get started with, and we would love to integrate those into our conversation. Please use the Q&A function for asking your questions. So these were great presentations from all of you. And I also should mention we've been joined by Dr. Carla DeSisto of the U.S. Centers for Disease Control and Prevention for the panel discussion. So I want to get started with a few of these questions that we shared in advance with our presenters and panelists. We often focus on changing people's minds. We just saw Noel's slide about the evidence that underlies that, and Noel highlighted that changing systems and behaviors are likely to have a greater impact. What are your thoughts about how can we better align health systems to make HPV vaccination the easy and the expected choice? What would you say in response to that?
How the vaccination program talks about vaccines is very important. So when the very top leadership has to be supportive of vaccination in a regular and public way, and that allows us to implement policies that are effective at nudging people towards vaccination. The alternative is to put friction in the system that makes it just a little bit harder at multiple levels, and then that can slow vaccination down.
Thanks, Noel. And I'm also drawn back, Natalia, to your quote from earlier that I used as a transition about the sort of inherent coverage gaps starting with policy gaps and program design. What do others think? How can we better align our health systems to make HPV vaccination the easy and expected choice?
Um, Sorry, did you want us to raise our hands, Heather?
We're a small enough group, so if we start talking over each other, I'll call on people, but I think we'll just let people come off mute and respond.
Okay, thank you, and thanks for having me here. I think another piece that can really help is kind of adding automated reminders. Many of our health systems, at least within the US, use systems like Epic, where the providers can actually have a pop-up come on their screen. You know, we know providers are so busy, and to many of us here, HPV is top of mind, but I really do feel for our pediatricians who are trying to keep track of all the different vaccination records and recommendations and everything else. So I think those pop-ups kind of help just remind the provider to talk to the parents or patient, depending on their age.
Mhm. And Natalia, you were getting ready to weigh in as well.
Yes, thank you. Apologize for my English, it's not my native language, but
Okay.
I think this is very important to understand what's happening in the community, what they are believing in HPV vaccination, because I think that the first thing is to validate what they are thinking and to understand, and then not to change what they are thinking about. So to understand what they are thinking is a lot of different communities, and in the region that they have a lot of beliefs regarding the vaccination. So I think that it's very important to reach this community to understand what they are thinking, and in this point to try to inform, not educate, inform the communities what the benefits of the HPV vaccination and the safety also.
I
And
really,
Teresa, go ahead, Noel, and then I'll go to
just
Teresa.
want to say the evidence is really on your side, Natalia. We often come in trying to tell people how it is about vaccines. One of the most important things is we need to listen. The announcement approach training that I referred to and that's in the chat starts off with a presumptive announcement because many parents are ready to go. You don't want to spend a lot of time talking about vaccination if they're ready to go. But for the parents who have questions, the first thing you do, you have to ask them, what's in your mind? What's your biggest concern? And have them talk about it for a moment. And then to say, I heard you say these things. And without them being able to talk and being clearly shown that someone's listening, they won't be able to hear anything that happens after that. And if you do, then all of a sudden you are in a conversation that's meaningful. The other thing I'll also sort of follow up on what you said, Natalia, is that we're often in a rush. And some of these conversations are going to take a while. And you don't have 15 minutes of clinic visit or half an hour, and school located is complicated too. So the announcement approach is like a 3-minute, 2-minute conversation. Have it over time. So have the conversation you're going to have one time and then follow up at the next visit. Or if you're having a community conversation, do it little bits at a time. Don't try to do everything at once. It takes a while for people to take on ideas that are different from what they're currently believing. And they may be open to it, but we can't force them to. We really have to be listening to them and be having a partnership conversation. So Natalia, thank you so much. It was great what you said.
And as I heard Natalia wrapping up, talking about people need to be informed, I was thinking of you, Teresa, who I've heard say many times that people need to just be informed. They don't need to be
Yeah, we
experts.
talked about that. I remember when you said that just now, I was like, he said it. I come from a perspective that I teach in low, middle, and high income settings in multiple faith-based spaces, indigenous areas, and there's a common denominator in underserved and hard to reach populations, as well as highly populated urban centers with booming economies. And the one key concern for everybody is cancer. And very young age people understand that that's something that's bad, cancer. And the common message that we've moved forward with in our clinical research projects, doing cervical screening, and in our psychosocial science work, doing education in sexual health, is that if you create a 90-second, you could call it a speech, where you include multiple key things that people need to understand. It's quite fascinating what happens when you're done your 90 seconds, what comes out of their mouth. And the question ends up being, where do I go? What time does it open? What street is it on? They're asking where they can have access to it. So it's a different kind of question that gets asked when you lead with key facts, because we predict those questions because they ended up getting asked all the time. When you go into those specific communities that you're emphasizing right now, in India and in other settings, like, you already know what the preoccupations were. You should at least know by the time you're educating. So I think in high income settings, having a conversation and listening to the concerns is one technique. But another technique, when you have a lot of people looking at you and they're not going to necessarily come and ask those questions, is take that moment to give action orientated information. You design your 90 seconds and be clear about what your goal in your audience is. Because if you're talking about vaccination, we're talking one thing. And if we're talking about screening, it's a whole other thing. And it's about a whole other topic. So coupling that can be a little bit tricky, can be accomplished. But Heather, as you mentioned at the very beginning, action-oriented information, carefully designed, is really showing a lot of benefits in many places where we're looking at what happens after you provide resources. People are seeking out those vaccines. They are calling those hotlines, and they are doing those action steps that we're telling them.
Maybe I can also just pick up on that point about being informed. I think that's a really important one. In that survey that I mentioned earlier, that was across Canada, we found that around 10% of Canadian parents or caregivers did not know if their child had received the HPV vaccine, and it differed among communities. It also differed based on compared to the Hep B vaccine, which is another cancer preventing vaccine. So I think it is important to understand why certain parents are not currently aware of whether their child has the vaccine or not. The other piece I think is that I think has been not only picked up by our panelists, but also in the chat, is that we do need to make it easy. Carla, I want to also emphasize what you were saying about reminders. I think there's a lot of evidence about the need for reminders that makes it much easier for parents and caregivers, as well as for providers. And then also catching people up and providing as many opportunities through our system in a systematic and coordinated approach to maximize opportunities for catch up. So I think that's another way that we can improve our systems.
Well, thank you. And I appreciate the complementary nature of all of these ideas that have come forth on the system level, and thinking about how other levels work to inform and strengthen the actions that are taken on a system and on a systems level as well. So we've had a few questions in the Q&A and also in the chat related to this next question. So HPV vaccination has really faced a lot of misinformation and undermining of vaccine confidence challenges globally, as well as in North America, which we've been discussing today. And in fact, one of the questions talked about TikTok influencer-driven narratives and how that myth and misinformation catches on and spreads very quickly. So what lessons have we learned about building resiliency into our vaccination programs to help lessen the negative effects of these disruptions or confidence crises that we've been experiencing? What do you see as lessons we've learned and how we can think about scaling those and amplifying those?
When they're left alone, they don't get better on their own. That we do have to do something. And whatever we do isn't going to be perfectly effective. You can't expect to jump in and solve it overnight. Another thing is that it's relatively few actors who are creating misinformation and incorrect information. So it's a small group that punches well above their weight. They seem like there are a lot of people, but they're not really a lot of people. A final one is that role of leadership cannot be underestimated. And this can be political leaders who are far from the vaccination space. When they speak, their voices carry a lot of weight. We have a lot of our identities packed around politics. When all of a sudden politics touches on vaccination, it can be really undermining because you lose half the audience, or at least a meaningful portion of the audience, no matter who's speaking. So wrapping those two things together creates this challenge that's very hard to get past. And then it also is that sometimes leaders in the public health are not fully able to speak in the way that they would like to, that there are limitations on what they can do, some of them being practical, that they can't, they can only say what's true, they can only say what the evidence has, can only sort of be aligned with what the organization is trying to do at the time. But insofar as they're able to, having vaccination program leaders speak publicly and be a face to the vaccination program is really helpful.
Thank you. Teresa, you're getting ready to add something as well.
I was going to I agree completely with what you just said there. I think that there has to be multiple factors. I think we also have to recognize that people, we just did a little survey in the area I live in Quebec, noticing that people aren't necessarily feeling that there's quality and health messages on social media anymore. So that is a good thing, because then groups like us that have people on the ground doing education in different spaces and having information pamphlets out, we have a better success rate. So I think that having those one-on-one or opportunities, in-face opportunities, using pharmacies to kind of lean on promoting us, using QR codes so that it links us to NGOs' websites. I think that that's on the up right now. That's what we're definitely noticing in Quebec. I see Carla's shaking her head, so I don't know if it's happening for you as well, but it's definitely an interesting time. I think that we have more ear in our interventions that aren't happening on social media, particularly, and the political power. I don't know if it's ever been stronger than it is now. The weight and the pull of our political situations of everywhere where we're living is kind of coming through how our HPV vaccination programs are being rolled out right now. So I think that's always an influx, and it'll probably be ever changing. And hopefully some of our places will do better. And like on my topic, include that pharmacy access. I think that's something that a lot of places would benefit from.
Thank you. Any other thoughts about how we take on the myths and misinformation that sometimes are pervasive and really infiltrating decision making around HPV vaccination? We've heard some great strategies and ideas here. I think most notably, don't let them go unchecked. Let's make sure that we build them into our proactive information that we're providing as well. Anything else you guys would like to add before we get to kind of the final wrap up here?
Yeah, I have two things. One is there is a resource from the World Health Organization called Addressing Vocal Vaccine Deniers in Public. If you have a public role and you have to speak with them, you want to know that you can rebut the incorrect information they're sharing directly, or you can go after their style of argument. You can say, oh, you're moving the goalposts. Oh, you're not accepting the same standards of evidence, and so on. Evidence shows that those are equally effective approaches. So if you go to the World Health Organization's website, you can find something called this training. You can just read through it on how to do this, addressing vocal vaccine deniers in public. The second thing is, if you're a provider, your voice really matters, has a big impact, and you may be concerned about what will happen if one of these people goes after your clinic. There's something called Shots Heard. They've changed their name. It's Todd Wolyn's group, WOLYN, and they will come to your rescue. They will come and help you address all this stuff and give you a workbook for how to do all that. But you're not alone, and there's lots of support for you. And speaking out is really an important thing you can do as part of your role as a healthcare provider.
Thank you, Noel. And I'll try to find the Shots Heard link to put in the chat about the WHO resource while you were mentioning it. Thank you. Okay, I want to close with this question, and I'll call on you for each of the panelists. If we look ahead 10 years from now, so 2036, or even extend it to 2040, what one HPV vaccination change will have made the greatest difference in advancing our pursuit of elimination? And Noel, why don't we start with you? What is that one change that will really lead us forward here?
One dose has many benefits for moving us forward in terms of equitable access. And there are more countries who are doing one dose than are doing multiple doses of HPV vaccine for the usual younger kids. Of course, there's lots of conversations about where that should go. The US has a couple different ideas going at the same time about this right now, but I'm really excited about the opportunity that this vaccine is so effective and may only need one dose.
Thank you. Carla, what would you say? What is that one thing we need to do to really get us closer to elimination?
I think really closing the gap on our disparities in vaccination coverage, specifically in the US, thinking about some of our rural communities, for example, that Sandy highlighted.
Thank you. And Sandy, what would you say that on the heels of
Well,
that?
Carla stole my thunder. I was going to
Oh,
say closing the rural urban gap that I pointed
yes.
out in the data slides and making sure that every adolescent, regardless of where they live, has equal opportunity to be vaccinated and has access to vaccines.
Thank you. Philip, what would you add?
I would say even more relevant as we move to a one-dose program in many places is robust, equitable, and tailored catch-up programs to making sure that if someone misses that opportunity, that there are many other opportunities provided.
Thank you. What would you add, Teresa?
I would say, I don't know, I'm looking at this question in a bigger sense, I guess. I would focus on mass vaccination where the burden of cervical cancer is its highest in the world. And just
Mhm.
mass vaccination, like what we want for North America, give it to where it's the highest burden. That would be the biggest thing I think that would,
Yeah.
I wish we would do that.
Thank you. And Natalia, the last word to you, and then we'll turn things back to
Oh,
Julie to wrap us up.
okay. I think that the change that will have made the greatest difference is achieving a high and equitable coverage with a single dose HPV vaccine schedule, primary through school vaccination, while ensure also the out of school adolescents are not left behind.
Thank you. Thank you. And thank you to all of our panelists. This was excellent content today. To wrap up our webinar series, I'm going to turn things over to my colleague, Julie Tarot, to bring us to the close here. Julie?
Thank you so much to all of our speakers. We've covered such a lot of ground in this webinar, and I hope our audience has really got some inspiration on one element at least to take home to their own programs. Sadly, we're going to have to call time today, but thank you for everyone that's contributed, also your questions in the chat. Yeah, we are going to move to a workshop in Montreal, and we're looking forward to running that workshop and also sharing that back with you if you can't join us in Montreal. So look out for that. But as this series come to a close, please look for our links. You can catch up on the recordings if you've missed them, and we have meeting summaries so that you can catch up on what we've covered across all of the three pillars. But it really leads, it's really up to us now to go back to our communities and really push forward for leadership in the region. We're looking for learnings from the North America to be shared globally. As Teresa said, we also want to reach those in other parts of the world that really need to prevent cervical cancer. So, please continue your great work and go that last mile in terms of elimination and vaccine uptake. And I'm sure together we can eliminate cervical cancer. So thank you, everyone. And we look forward to seeing you in Montreal.